Today. I'm Satish Gopal. I direct the Center for Global Health at the National Cancer Institute in the US. Our NCI Global Cancer Research and Control seminar series features talks by researchers and cancer control experts who are conducting impactful and innovative work that is addressing cancer morbidity and mortality worldwide. Today, we're really delighted to welcome Professor Anna Schuh virtually, who will talk about improving the diagnosis of Burkitt lymphoma in East Africa. Dr. Schuh completed academic and clinical hematology training at Oxford in the UK. From 2006 to 2014, she was the clinical director of the hematology laboratories, including molecular diagnostics of Oxford University NHS Hospital Trust, one of the largest NHS trusts in the UK. Since 2006, she's led more than 50 early and late phase clinical trials for CLL as principal or chief investigator. A number of these have changed clinical practice for patients in the UK and worldwide. She served as chair of the UK CLL Forum from 2015 to 2018 and chair of the National Cancer Research Institute Collaborative Group for CLL from 2018 to 2022. Her research interests are focused on the development, evaluation, and implementation of new technologies for precision diagnostics. Her research group published the first genome-wide longitudinal study of the changes in the genomic landscape of patients undergoing treatment for leukemia, and subsequently led pivotal whole genome sequencing studies in collaboration with Genomics England. During the last 5 years, her group has focused on evaluating whole genome sequencing of liquid biopsies for early cancer detection. She published the first ever deep whole genome analysis of circulating tumor DNA in solid tumors, and now oversees research programs evaluating the clinical utility of liquid biopsies for early cancer diagnosis in the UK, Uganda, and Tanzania. Indeed, she's joining us, I think, very graciously from Tanzania today. She also became a member of the MUHAS faculty in Dar es Salaam, Tanzania in 2019, and actively contributes to their hematology graduate program. She is the PI of a 5-year program funded by the UK National Institute of Health Research to improve diagnosis of aggressive infection-related lymphomas in East Africa, a program called AI Real, which is what she'll be speaking about today. She's authored more than 150 papers with an H-index of 49 and over 8,000 citations since 2017. She holds a patent for non-invasive prenatal diagnosis of sickle cell disease, has been a co-founder of 2 biotechnology startups, and most recently of Seren, a social enterprise to improve access to DNA-based diagnostics in Africa. Before handing over to Professor Schuh, I'd like to quickly just review a few logistics. First, please save your questions for the Q&A time immediately following the presentation. You may type your question in the chat box or use the raise hand feature found under reactions. Second, please note that today's presentation is being recorded and will be available on our website at cancer.gov/global-health. Finally, you can find information about future presentations on our website, cancer.gov/global-health, and by following us on X at NCI Global Health. And so we'll begin now. Welcome, Professor Schuh, and we'll hand over to you. Thanks so much for joining us today.
Yeah, thank you very much, Satish, for the kind introduction. If you stop sharing, then I can start sharing my screen. Oops. Okay. As Satish has already pointed out to you, I hope you can see, you can all see the slides. I'm going to talk to you today about the AI Real program that stands for Aggressive Infection-Related East African Lymphoma Study. And before I start, I always these days start with these 2 pictures. One is the skyline of Oxford, where I've spent the last 25 years. And then underneath is the Tanzanite Bridge in Tanzania and Dar es Salaam just before it was finished. And it is now finished, and it always reminds me of the various gaps that we have to bridge, or we should be bridging, or aim to bridge when we are working in global health. So I'm aware that there might be some audience present today who is not that familiar with hematology or indeed with Burkitt's lymphoma. So I thought I'd start off by giving a very, very brief introduction. into the topic. Burkitt's lymphoma in its endemic form, so in sub-Saharan Africa primarily, is caused by a virus called the Epstein-Barr virus. It makes up to 50% of childhood cancers globally. That might surprise people on the call, but it's because, number one, there's lots of children in sub-Saharan Africa, and number two, it's because it is actually quite common, with an incidence of 3 to 6 per 100,000, which is more common than other childhood cancers. As I said, it's common around the Great Lakes of Africa. It is associated with malaria, but it's also associated with Epstein-Barr virus, and the exact pathogenesis remains to be elucidated. It has recently been found to be involved in the pathogenesis of multiple sclerosis in the Northern Hemisphere, and it's of course since then that vaccine development is in progress, although Burkitt's lymphoma in children in sub-Saharan Africa was the first viral associated cancer to be described in the early 60s. So it's rapidly fatal unless treated with chemotherapy. In high-income settings, about 90% of children are cured with chemotherapy. In sub-Saharan Africa, that number is more or less 50%. The treatment is, however, generally available and is funded by government agencies. Late diagnosis is regarded as one of the key factors leading to high death rates. So the conventional diagnosis requires invasive biopsy, followed by pathology review. Sometimes it is possible to establish a diagnosis from a fine needle aspirate, but that is in the minority of cases and requires, in any case, specialist surgeons and or pathologists, of which there are not enough in sub-Saharan Africa. So the aim of the AR-REAL study has been to improve accuracy and speed of diagnosis of Burkitt's lymphoma in children from Uganda and from Tanzania. There were some 4 main objectives. Number one, to establish the root causes of diagnostic delay in 2023, to evaluate mobile whole slide imaging for the diagnosis of EBV-driven lymphomas, to assist pathologists in helping them make the diagnosis so that maybe fewer pathologists would be needed, to develop and evaluate a liquid biopsy test for diagnosis of EBV-driven lymphomas, to reduce the need for invasive biopsies. So the liquid biopsy is coming from a simple blood test, a blood draw, and then to evaluate safety and efficacy for adding rituximab to the chemotherapy backbone, COM, in the frontline treatment of Burkitt's lymphoma. The AR-REAL study included sites in Uganda and in Tanzania. So we recruited patients from Lachor, which is in northern Uganda, where the children with Burkitt's lymphoma were first described in the 60s. And then we had sites also in Tanzania, at KCMC, in Yamoshi, Bugando, at Lake Victoria, and then at the National Hospital in Salaam, where many of those children are referred from other parts of the country. The AR-REAL study is a prospective clinical data and sample collection study, with the main inclusion criteria being children from the age of 3 years to 25, so young adults with suspected lymphoma. So anybody with lymph gland swelling, night sweats, unexplained weight loss, and a suspicion of lymphoma presenting to secondary or tertiary care was eligible to be entered into the study. We have recruited 379 children and young adults, and the study is now close to recruitment. Recruitment started in early 2020, late 2019, depending on the sites. The primary endpoints were the time from initial symptoms to diagnosis and then to treatment, the diagnostic accuracy of using mobile whole slide imaging, this was established using a CAP-compliant assessment criteria, the diagnostic accuracy and turnaround time of a liquid biopsy approach, and then safety and efficacy of a combination of COM with rituximab compared to COM alone in a before and after study. So I'm going to go through the different components of the study and the initial results in more detail now. Some of this is published and some of it is remains unpublished. So the first important finding we have now published is that diagnostic delays are still a reality for all children with suspected lymphoma. And you can see from the graphs here on your left-hand side that the not started treatment probability of 50% was, and the treatment delay in days was over 100 days for all patients. When you looked at this in terms of the underlying diagnosis, not unexpectedly, patients with Hodgkin's lymphoma presented even much later, were treated even much later. Patients with Burkitt's lymphoma and diffuse large B-cell lymphoma had a shorter time to initiating treatment, and one was able to see from the data that there was very much an awareness within the healthcare system to fast track patients with Burkitt's lymphoma through the system. But despite of that, the delay was about 100 days from initial diagnosis to finally starting treatment. Now, 2/3 of the diagnostic delay is really within primary and secondary healthcare facilities, and this is what we identified as one of a newer finding, because in the principal other studies there was a lot of emphasis on lack of awareness within the communities of the severity of Burkitt's lymphoma, or indeed of cancer in general. Whereas what we highlighted here was that in blue and in gray, that actually 2/3 of the delay was because of either not referral to secondary care, or in fact delays within the secondary care pathway, all to do with the lack of access to surgery or to pathology. In particularly, the pathology delay was much more significant when state-of-the-art WHO immunohistochemistry was applied, because it was the immunohistochemistry that made up the vast proportion of the diagnostic delay within pathology. So we then moved on to evaluating mobile whole slide imaging. So just to be very clear what this is not telepathology in the conventional sense. So it's not just about taking a picture from a slide, because then at that point you need to have someone who understands the picture and has got pathology background knowledge to take the picture. The advantage of whole slide imaging is that literally anybody can put a slide through a scanner, and then the entire slide is scanned, and a pathologist who is trained can then look at the image remotely. However, most of the whole slide image facilities available are static scanners. They are very expensive. They're close to $100,000 US in purchase cost, and so we wanted to evaluate a mobile scanning device. In this case, it came from a small startup company called Alexapath. The other advantage, the advantage particularly of a mobile scanner, is its affordability, and it's easy, can be easily transported for more easy repair, and it's therefore ideal for remote regions where there's no clinical pathologists or specialist staff, so they can then just scan with a very simple device the entire slide, and that can then be reviewed remotely by pathologists. So that's really the idea behind it. Now, we performed a CAP-compliant comparison between glass slide microscopy, so that's a GSM, and the whole slide imaging. And we really scored the slides and the digital images that we obtained according to whether this is lymphoma, metastatic, or reactive. And you can see that there was a very good concordance. However, it was not possible to further differentiate different types of lymphomas using this technology, because the image quality was just not good enough. So what we concluded was that this could be used as an initial screening tool. However, there was also a very important challenges with it. There was on some images a very poor quality of the images that came from the scanning. Of course, there were also some slides that were excluded initially because the embedding was poor and the fixation on the slides was poor, and of course that would cause poor slide image quality both on the glass slide but then also on the digital image. The device was not very robust. The robotics were not very robust, and there was actually long holdups when it came to the repair. And then most importantly, the software and the hardware support for sharing and storing images was not sufficient and was not really adapted to the reduced bandwidth that we find very commonly in remote areas, especially in sub-Saharan Africa. So there are still challenges. Now, most importantly for our study, whole slide imaging still requires referral to secondary care, and it still requires an invasive biopsy. So actually it does not really get rid of the healthcare related delays that we identified at the very beginning of our study as being the important factors of delay. So we therefore went on to have a look at liquid biopsies. These are simple blood draws that contain lots of things, but particularly circulating tumor DNA, and in patients with any type of cancer, but in our case, of course, in patients with lymphoma. So we looked at and this tumor DNA is shredded from the tumor through apoptotic processes, necrosis, and also in some cases through active secretion. It's importantly, it is obviously not very abundant, so there's very small amounts of circulating tumor DNA, and it's also highly degraded. So when it comes to designing next generation sequencing devices that capture these very minimal amounts of circulating tumor DNA, they have to be designed in very particular ways. Now, the advantage with Burkitt's lymphoma is that there is a pathognomonic translocation, so a very specific genetic abnormality that is present in all cases of Burkitt's lymphoma. And we designed our next generation sequencing panel around this translocation, and that includes MYC, and it includes the immunoglobulin loci, either the light chain or the heavy chain loci. And so we basically designed the panel that it would fit very well to reveal circulating tumor DNA that would come from endemic Burkitt's lymphoma. However, the limitation of the panel was that it also had to be quite cheap and affordable. So we did not actually cover all the different breakpoints that have ever been described in Burkitt's lymphoma, but only about 50% of them. And that means that some of the cases remain translocation negative, but I come on to this. Importantly, we also used Epstein-Barr virus, though, and the signs of integrated DNA, EBV DNA, as another sign, a second sign of the presence of Burkitt's lymphoma. We didn't just look at the EBV level, so at the amount of copies of EBV, but we were also able to look at the proportion. That means the proportion of the total reads in the sample that map to EBV, and then the EBV size ratio, which is basically a ratio of the EBV reads over the proportion of autosomal reads within the same size window, and then also the EBV entropy, which is the essentially the fragment, the variation of fragment sizes across all the EBV reads. So there's various different modalities within the EBV circulating DNA that we were able to look at. So all the sequencing and all the analysis of the samples was performed in country. In Tanzania, it was done at MUHAS at the University of Health and Allied Sciences in Dar es Salaam, and then at the National Central Public Health Laboratory in Kampala in Uganda. We've sequenced close to 300 samples now. And this is the lab, roughly the lab workflow. and you see the very successful lab scientists here. So in terms of the bioinformatics, again, we were trying to build capacity within the African team in bioinformatics analysis, both with respect to medical statistics, but then also with respect to pure bioinformatics and sequencing analysis. So as you can see, with respect to the univariate analysis across all the clinical parameters of our children tested, we identified that the jaw presence of a jaw tumor was clearly associated with the presence of Burkitt's lymphoma, and for the clinicians on this seminar, that's not unexpected. But then you can see also that the different EBV parameters were also highly significantly associated with the presence of Burkitt's lymphoma. We then used machine learning using various different statistical models to understand, the contribution of the different parameters that we've tested to the sensitivity and specificity. And I'd like to just draw your attention to the last data point of each of the panels, where you see the full model, including the translocation. So really, as you go from left to right, you see that the sensitivity and specificity and positive predictive value increase, and that is because we are just going away from having a simple measurement of the amount of cell-free DNA to adding the clinical parameters, then to adding the EBV parameters, and then at the end to adding the translocations into the model. All of that increases sensitivity and specificity. So at the end, we find ourselves with a specificity of 92%, and a positive predictive and negative predictive values of well over 80%. Of course, there is not all in terms of the sensitivity, we are still missing some patients, and in particular the patients who are sporadic Burkitt's lymphoma patients, because they don't have EBV, they're not EBV positive, and that is a caveat within the model. So in the second phase of the program, we then wanted to evaluate the turnaround time and the more general clinical utility of the liquid biopsy assay. Our median turnaround time across Uganda and Tanzania was 11 days. The fastest was in Uganda, a 6-day turnaround time from northern Uganda to Kampala. As you see, we have automated reports that the system generates for each patient, and that can then be handed over to the clinicians and discussed in a multidisciplinary team meeting. So that's really how we ran the study until last summer. Where are we going next? So we presented the results to the Ugandan Ministry of Health representatives, and we're working with the national lab in Uganda. They're already running the test, and they're very familiar with the test. So in Uganda, they have a national sample transport network that was established as part of the HIV viral load measurements, and they've now identified sites within Uganda who would also refer liquid biopsy tests of kids with suspected Burkitt's lymphoma to Kampala, so that the diagnostics can be established really quickly. Now, in terms of the what I think I didn't mention at the beginning, as part of the program, we decided very early on that the children participating, and also children who were approached to enter the study but then declined, or the parents declined to participate, all of these potential participants should be given the rituximab, because rituximab is the standard of care treatment together with chemotherapy in high-income settings for children with sporadic Burkitt's lymphoma. And that is based on a big randomized controlled study published in the New England Journal of Medicine a few years ago. So we decided that we wanted to make rituximab available as part of the study to all our children. And you can see from the timeline here that partly because, well, to a large extent because of COVID, there were some delays in in red here of patients actually receiving rituximab, and in the later stages of the program, more and more children then were able to obtain rituximab for their Burkitt's lymphoma. So we had some exclusion from this analysis, but not many actually, when you consider that this is a study performed in lower income countries. 15 patients were excluded, 35 received standard chemotherapy, and 47 received R plus standard chemotherapy. And then 32 and 40 were included in the final analysis. The important first measurement we wanted to look at, because obviously these are children from different ethnic backgrounds, so we wanted to ensure that there were no unexpected side effects. The number of grade 3 and 4 adverse events with standard chemotherapy versus standard chemotherapy plus rituximab are listed here. It is fair to say that more patients finished 6 cycles of chemotherapy when they received rituximab, and more patients were able to receive second-line treatment after the initial assessment after 2 cycles when they were given rituximab upfront. In terms of the adverse events, there were more adverse events overall with rituximab. However, when you looked at them individually, there were none of them came up as statistically significant. But it's kind of the usual suspects of febrile neutropenia, neutropenic sepsis, where you might think there would be more with rituximab than without rituximab. In terms of the secondary endpoint analysis, so this now refers to the event-free survival and the overall survival of patients treated with either standard COM or standard chemotherapy plus rituximab without switching, so without all the patients who were in a complete remission clinically after 2 cycles of treatment. You see that there's a statistically significant advantage of patients treated with rituximab as opposed to without rituximab. And the same also applies to overall survival, with a very significant overall survival advantage of the patients treated with rituximab. Now, the median follow-up time of this group is 8 months, so this is quite short, but at the same time, we know that most of the patients with Burkitt's lymphoma will unfortunately die very quickly from treatment. Now, when you look at the entire cohort of patients, so including also those who switched after the second course of treatment, you see that there's still an overall survival advantage of patients treated with rituximab, and the follow-up in this patient group is now 14 months. So that's actually very encouraging. Last but not least, I also wanted to highlight what we did in more sort of mechanistic science, and what we started to do as one of our collaborators in Uganda was able to obtain a Commonwealth grant to actually do his DPhil in the United Kingdom, in Oxford. So he is now looking at whole genome analysis of Epstein-Barr virus isolated from children with Burkitt's lymphoma, and compares this to EBV isolated from healthy controls from Africa and also from China. This is previously published data. And I just want to show a little bit of a data here, where you see in the circus plot with the circus 4 being the healthy controls, and this circus 3 being the EBV isolates. You see that the healthy controls have a much lower mutational frequency compared to the EBV isolated from the Burkitt's lymphoma patients. And when you look at some of the interesting mutations that occur much more frequently in Burkitt's lymphoma patients with very significant p-values, then some of them are, these are only the ones that have got very highly significant, predicted to have highly significant impact on protein folding, and they occur in genes that are clearly important for EBV function. So we don't know at the moment what this means. Obviously, a lot more work needs to be done. But clearly this might be data that in future at some point could be relevant for vaccine development. So the project was not just about science and about laboratory, but we basically, as I already said, are now at the point where we've engaged with the Ugandan Ministry of Health to create some form of sustainability in running a national pilot in Uganda for that would essentially give out results through the multidisciplinary team meetings that we've developed on a regular basis for patients. In Tanzania, we've adopted a different sustainability model. So we basically created a social enterprise. This is a company limited by shares, so it's a private entity, but it engages in public-private partnerships with the National Hospital and also the university and other public hospitals and institutions. And it provides haematology diagnostics, not just for Burkitt's lymphoma, but for many other hematological diseases. And then we have done a lot of work both with adults and with children and patient and parent association around raising awareness of cancer. This is just one of the examples of 3 cancer survivors from Tanzania who are very much involved and running regular podcasts about cancer survivorship in Tanzania in the local language in Kiswahili. So I will stop here. I mean, the most important message of this slide is that, I'm just here to tell the story. The work was done by a lot of extremely dedicated and talented people, and I'm very proud to be part of this team and to enable students on their various stages of their career to progress onto the next level. And I stop here, and I'm very happy to take any questions. Thank you.
Great, thanks so much, Anna, for a really wonderful talk. So we have some healthy amount of time now for questions. So we'll invite everyone to turn on your cameras if you feel comfortable, so we can see each other during the discussion. As a reminder, you can type your question in the chat, or use the raise hand feature if you feel comfortable, found under reactions, and wait to be called on. When called on, please unmute yourself and ask your question, and we'll get to as many questions as we can in the time that we have. So Anna, maybe I'll start. I had a couple. So first, one is a clinical question and one is kind of a scale-up question. So just, we have some experience, I think, introducing rituximab in Malawi. And I was interested that it seemed like children with Burkitt who did not receive rituximab received fewer cycles of first-line therapy and were less likely to receive second-line therapy. And the explanation for that was not immediately obvious to me. Do you have a kind of explanation for why that occurred in your study population?
Yeah, I mean, we basically think that they survive longer. I mean, we kind of obviously we thought about maybe there's a bias because they get more attention because they get rituximab. So that's clearly, we can't completely exclude that. Having said that, because we have got this control cohort that is was also part of the study. All these kids were recruited into the study. They were all consented. So their data was collected. They were on the radar of the clinicians. I think that is more unlikely. If anything, I think initially, if there was a bias, when I'm talking to the clinicians across the different sites, it was that because there was limited availability of rituximab, the rituximab was reserved for the kids with a poorer prognosis. So it's intriguing to see. It's certainly not what I had expected, because I had expected that the rituximab would not make us absolutely no difference. But clearly the data shows us otherwise.
Great, thanks. So a reminder to everyone, feel free to raise your hand or put questions in the chat. I'll ask my second question now, which is, based on your experience introducing sequencing and some of these DNA-based diagnostics, in Tanzania and Uganda. I'm curious what your thoughts are, having tried to operationalize this. What do you think is the scalability of this? Like 10 years from now, do you see this as samples being sent to Kampala and Dar and being processed centrally? Or do you think there is the ability to migrate some of these advanced liquid biopsy technologies even out to the periphery, closer to patients? What is your vision for kind of the next decade in this field?
Yeah, this is a very good question. I mean, number one, clearly at the moment, when you're looking at the health economics of it in a small research program of a few hundred kids, it's very difficult to make a health economic case. Although my health economists, and I didn't have time to talk about this, they work on the premises that for as long as we are improving the overall survival of children by about 2%, then this is hugely health economically viable, because the cost is much less than 2 times the GDP per test, which is generally being the cutoff that the WHO would apply. So I think if you apply the health economic rules, then the test is already hugely health economically viable. However, if you want to maximize economy of scale, then initially a centralized model is probably the way to go. It also helps with quality control, of course. So I didn't say this, but we have a HIPAA compliant cloud that can be used jointly by our collaborators in Tanzania and Uganda, and then also by the Oxford team, where the quality, where we can go through troubleshooting and quality control and so on. That would be much more difficult, I guess, to do in a decentralized model. Having said that, we are working on switching to other sequencing technology, so that the algorithms that we are using for the analysis is the same, but the tools that we would be using for sequencing are much easier to use tools. They are decentralized. They don't need big equipment and big capital investment up front. They don't need that much maintenance. I think we all know who we're talking about in terms of the ideal sequencing provider. So we're working very closely with the company there to actually see whether this technology can be used in a different way. In particular, the translocation detection using long read sequencing, of course, is also very much, at least theoretically, a potential advantage. So yeah, so in answer to your question, I do see within the next 10 years for this to be a decentralized model. But I also think that there will be there will have to be a lot of emphasis then on quality control.
Yeah, thank you. I just want to agree with you about the health economics point. I think we've done some detailed modeling around, for example, the introduction of rituximab in Malawi, which seems very expensive on the face of it. But when you're dealing with curative, time-limited therapy for patients who then often have decades of event-free survival subsequently, from a health system and lifetime horizon, I think these can be extremely cost-effective when the modeling is done rigorously.
Yes. And also the other point that my colleagues from Uganda made, who were very closely involved in the HPV rollout of HPV analysis and HIV viral load, they remember still the days when people were saying, oh, this is never going to be, any nucleic acid test is going to be always too expensive for sub-Saharan Africa. And here we are 10 years later, and everybody is actually using them. So a lot of it is within the economy of scale. The same applies to supply chains. If there's a regular demand, then supply chains will follow.
Yep, those are terrific points. We have time for additional questions. Does anyone have another question? Paul, I see you unmuted. Did you have a question?
Sure, yeah. Anna, thank you so much for your talk. My question is going to go a little beyond the scope of what you talked about today, just because I'm interested in your opinion. Both in terms of economics and implementation, I'm curious, as we're starting to see this explosion in research and applications around multi-cancer early detection in high-income countries, what are your thoughts around the future deployment of some of those tools in more resource-limited settings?
Well, I think the learnings that we've had, one of the learnings of the last 5 years on with the Burkitt lymphoma test was very much that pathology services are severely restricted. CT scanners, there's not enough of them. MRI scanner, there's not enough of them. And very often, actually, this very limited resource is not put to its best use. So people are accessing the facilities because they can afford to access them, but it's not because they necessarily need them. And otherwise, you have got people, you know, who really need a CT scan because they have a high suspicion of cancer, but they can't get, or endoscopies, you know, and they can't get access to them. So where I see the role of the liquid biopsies going forward is as a triage tool. Obviously not in someone who turns up with a breast lump, because there we know it could be breast cancer, so you do something more target, but in patients with non-specific symptoms, of which there are many. And in the UK, we've there's a study that was published in September of this year from colleagues in my institution, and they basically proved or tried to prove exactly the utility of this type of test in the NHS in the UK as a triage tool, because the waiting times to access CT scans and to access endoscopies, etc., are just unacceptably long. And when patients present to general physicians, the general physicians, they don't really know, is this cancer? Is this not cancer? Weight loss? What could it be? Now, clearly, those patients then usually need access to additional imaging, but in a healthcare, in a resource restricted environment, at least those are then, those CT scans and those endoscopies are then put to their best use. And that's really where I see a very strongly a use case, and it's to do primarily with the with the accessibility of these tests. They feel you get the sense, oh, these are complicated tests because they're DNA-based tests and we need bioinformatics and so on. But actually, in the great big scheme of things, it's the same test for would be the same test for every cancer. So it's actually quite easy to run, much easier to establish than a CT unit, where you need PET CTs, you need a bunker and so forth and so forth. And, certainly I've seen here in Salaam, it's taken years to get PET CT into the country. So anyway, I think that's really where I see the use, triaging, speeding up, avoiding unnecessary traveling, to India or to even a tertiary cancer hospital when that is 8 hours, 12 hours by bus away. That's where I see the potential use.
Thanks, Anna. Are there other questions for Professor Schuh?
Professor Schuh, this is Kathy, and I wanted to ask a question about the consenting process and how you might have how you are managing some of the challenges that are typical in low resource settings. Thank you.
Yeah, so we had a team of pediatricians and supervised by pediatric oncologists. We were basically really embedding the program into the hospital, because one of the things I like about this type of research is that it drives quality of care. So whilst you're performing research, you're at the same time, because you're applying SOPs and standard protocols, you're also very much enhancing the quality of care. So the actual consenting was performed in various different languages. So we've had written patient and parent information in both in Kiswahili, in Luo, in English. It was done by doctors who were trained in GCP from either the NCI or from the NIHR in the UK. But then on top of that, they received study-specific consent training as part of the issue, when they were brought onto the study. And the consent procedure itself was then according to the national guidelines. So everybody had a 24-hour period where they could change their mind. We couldn't give much more because these kids are, they're usually quite sick. And it was obviously made very clear to the parents that irrespective of whether they consented or not to the study, there would be no change in their in the clinical management of the child. So that's why we, everybody received rituximab irrespective of whether they consented or not. Yeah, I think that was made very clear. We had a screening log. So initially we had, I think maybe 3 or 4 parents who did not consent, and this was because they had not understood. They basically felt, oh, if I go into the study, then I might get this or I might not get that, and there was a bit confusion. So we had to really stress the point that everybody would be treated exactly the same way, irrespective of if they were in the study or not. Yeah, I think overall, we try to follow very much a clinical trial approach. So this was not like a retrospective data collection or sample collection. It was all prospectively done. Patients were recruited. We had delegation logs. We had training logs. We had the consent forms. We had regular audits, inspections of the of the trial and the site files of each of the sites, so that we knew where the weaknesses were, and then we can then use training to enhance the protocol and to enhance the consent procedures. This was quite challenging during the pandemic, but it was basically myself on the war zone insurance, traveling around the country and doing audits and making sure that the training was happening. And we didn't have much in terms of turnover in the staff. So all the original staff remained with the study until the end, which was hugely beneficial, because we realized that obviously if we encourage career progression and we help with writing papers and so that people and also
registering for master programs, it was very important that to retain staff was one of the good things about supporting and mentoring, is that actually you manage to retain the staff. And so the training is quite important at the beginning, but then over time people get very used to it. Thanks, Anna. If there aren't other questions, maybe I'll ask one more before we perhaps let you go. It's sort of related. I'm curious if you encountered sensitivities, particularly with the regulatory authorities, about deposition and analysis of genetic data using a cloud-based portal system. I mean, it sounds like you've navigated that successfully in 2 countries. So I'd just be curious about that experience. It comes up quite a lot. I mean, I have quite a lot of experience, handling these issues myself, but I'm curious what you learned from navigating those challenges. I mean, the truth of the matter is that I don't navigate anything, but it's being navigated for me. And so one of my main learnings really was that I learned how to delegate and how to direct, thanks to global health. As you know, I joined global health really late in my career, and it's at the time point where I don't really need this for my own career, so which is a huge advantage. So I can actually mentor and just delegate, and that's what I did. And if people locally take ownership, then I think some of those issues they don't go away, but they're certainly much easier to address, because it's people from the country collecting data for the country, and so it's a different story. Now, having said that, there are rules and regulations around DNA testing, definitely, and it was very clear also from the outset when we submitted for approval in both countries, is that we specifically said we will not export any DNA samples out of country. So it was written into the protocol that we would not do that, and that was basically the reason, was that we wanted to create capacity within country. So the data itself is, we created a HIPAA compliant cloud, but this cloud is accessible to the Tanzanian and to the Ugandan researchers. And we are, as in Oxford, bioinformaticians are chipping in, but it is effectively a cloud that we build for the local researchers.
Obviously, everything is completely anonymized that is in there. We don't have whole genome data in there, so the specifics around whole genomes do not really apply for this study. And it's only acquired. We have not sequenced any germlines either.
Great, thanks so much. Kalina, looks like your hand is up, and maybe we'll make this the last question unless there are others.
Yeah, thanks, Satish, and thanks so much, Professor Schuh. Really wonderful to hear about this. Can you all hear me? It looks like I've frozen.
Yes, yeah, we can still hear you.
Okay, good. And actually, your last response just kind of made me want to ask, I guess, this final question, which is obviously a lot of the success that has happened is based on these wonderful collaborations that you have built globally. And just wondering from your perspective, if you can share some of the key aspects that have made those so strong and that sort of have made those what seems like very sustainable and empowering local scientists. Would love to hear your perspective on that. And thank you again for the great talk.
Yeah, thanks a lot for liking my talk. I basically I think the key element of this is the philosophy of your approach, right? I think helicopter science is dead, and I know it's a buzzword, helicopter science, but what I think is personally what I think is really important is that you respect the local culture, the local thinking, the local communities, and what their ambitions and what their thinking is and their interpretations is, and that it becomes essentially a question of mentorship and encouragement. And that's really where I see my role. So I keep saying I don't want to be a last author on any of the papers. Obviously, on some of the posters they made me last author. I don't really want to be that. I think they need to, people need to gain the confidence and find the confidence in them to step forward, and that is not always that easy, because when you think about the school systems and your education systems in those countries, they are very often do not encourage children to think freely necessarily. The political systems might not allow people necessarily to express their opinions freely. So for me as a scientist and clinician, my role is to encourage people to speak out. And in this case, obviously, it's kind of simply about science and about scientific findings, and to question them, and to sit down and think about your data and think again. And this is really where I see my role. I don't see my role in publishing a paper. I see my role in encouraging the people other junior researchers to start thinking. And that encouragement, it needs more encouragement and more mentorship in countries where that's free thinking might not be necessarily taught everywhere. I don't know whether that makes sense.
Thank you, Anna. There's maybe a couple of final questions that I think are pretty straightforward in the chat. So Pauline is asking about how long the follow-up for enrolled children will be. And then if you actively search for patients in the community, or if they came forward to the health facility as a first contact.
Right, so very good questions. So the first question relating to the follow-up, we just had a discussion about this today, because we appreciate that the follow-up at the moment is quite short. However, we also know that when you look historically through other similar efforts, it's very difficult to get complete follow-up data, let's say over a year after the children finishing a treatment, because they go back to their local communities where they live, and then it becomes very difficult to chase them. So it's no point having a 24 months follow-up if you only have it on 30% of the patients. So we decided we had to do some form of compromise, but we are going to follow children up for at least 12 months after end of treatment. That is which we think from a clinical perspective is a reasonable time point. The second question, just remind me again. Already forgotten. It's in the chat.
It's about whether you were actively.
No, so we didn't actively search. So basically, we the point of presentation was in the secondary or tertiary healthcare facilities, which was a range of different types of hospitals. It could be a Catholic hospital or a hospital run by the church, a general facility, or it could be a university hospital like in Dar es Salaam. But we then went and asked the question, when was the first symptoms? When did they start? When did you first present to either a traditional healer or a primary healthcare facility? And then we measured all those different time points. And that is published now in Blood Advances as a paper.
Great, thanks. Geraldina, your hand's up. We'll give you the last question.
Yeah, very interesting talk. Mine is really quick. I didn't, maybe you said it, but were any of the children that were enrolled, were they HIV positive? Did you know their HIV status?
Yes. So again, this will be in the paper. There were very few. I think from memory, there's actually only 2, very few, but surprisingly no numbers of HIV positive children.
Yeah,
What
Geraldine,
about-
I think basically all pediatric Burkitt series from
Yeah.
Africa are less than 5% HIV prevalent. So the Burkitt
Yeah.
that occurs is in older people with HIV, adults. So
What about malaria exposure? Does that
A
does
lot.
that in-
A lot. So that's one we were not able to do like formal testing, but we just went on the history, and literally all the children had been malaria exposed.
okay, well, I want to be mindful of time, and so I think we'll end it there. Anna, thank you so much for joining us today. I just want to quickly remind people that our last seminar of 2023 will be on December 14th with Dr. Christian Ntizimira, who will talk about constructing a culturally sensitive palliative care system, the importance and methodology of collaborative design with the Rwandan community. You can all visit our website, cancer.gov/global-health, to find information about upcoming sessions, past recorded sessions, funding opportunities, events, news, and more. And also follow us on X at NCI Global Health and on LinkedIn. So Anna, thank you so much. Look forward to seeing you soon. And sorry I missed you in person in Dakar.
Yeah, no, be at ASH.
Okay, thanks everybody.
Thanks. Bye-bye. Thanks a lot for having me.